Hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, and I am streaming live from the Moses Lake Professional Pharmacy studio. Actually, I'm streaming in my office right now, and I am super excited to have Zak Holdsworth on our podcast today, our midweek podcast, and he is the CEO of Hint Health, and he supports DPC, doctors, clinics. DPC is direct primary care. We've talked about him many times on this show before. We are big supporters of him. I wrote about him in my book as one of the fixes to our healthcare system. And he's going to define DPC a little bit just for those of us that don't know. And then he's going to talk about how Hint Health supports him. So, Zak, welcome to our show.
Hey, thanks for having me. I appreciate it.
Go ahead and give us a little introduction of yourself, and then we'll talk about what DPC is and what Hint Health does with DPC.
Yeah, good to meet you, and thanks for having me. I'm Zak Holdsworth. I'm the founder and CEO of Hint Health. We support the DPC movement, basically a technology platform that helps them with their billing, with their EMR solution. We've got pretty much everything we do is designed around supporting DPCs, our annual conference, our education programs. DPC is direct primary care. It's an alternative to the traditional kind of fee-for-service insurance-based medicine. Instead of doctors kind of working within the insurance fee-for-service status quo, which is really kind of not doing a good job of allowing doctors to care for patients. These doctors are charging an affordable monthly fee, anywhere from 50 to $100. The median's about $75 a month. And with that, they're essentially giving their patients unlimited access to them and their teams, same day, next day appointments. Really just profound care is able to be delivered when you can change the underlying business model. And also, importantly, able to help either patients individually or their employers save money because they're kind of working on behalf of the patient as opposed to working on behalf of the system. And so we're really kind of great supporters of DPC. We think it's one of the solutions to the US, perhaps the most important solution to the US healthcare crisis. And so we built a company dedicated to supporting the growth and success of this movement.
Yeah, I'm with you 100%. It's definitely one of the big fixes of the system. What we're doing now is not working. It's not sustainable. Traditional insurance-based medicine is expensive. And we always talk about how healthcare is expensive, but when consumers pay for healthcare and have direct access to their doctors like DPC, it's very affordable. Like you say, $50 a month for unlimited access to a doctor. So what's expensive is insurance-based healthcare. So that's what we really need to get in mind, is that when we take that third party out of the equation, and consumers are in direct access with their primary healthcare professional and pay them directly, it cuts out a middleman and it makes things much more affordable.
That's right. Yeah, it does.
Yeah. So tell us, what made you start? How long has Hint Health been around, and what made you start Hint Health?
Yeah, we've been around since around late 2013, early 2014. So 8-9 years or so. Me and my co-founder, we were trying to figure out, we tend to be sort of systems thinkers, I guess, and we're trying to figure out, we were looking at idea, we wanted to do something, a new company in healthcare, and we were looking around trying to figure out what is something that in theory would actually fundamentally transform the system, as opposed to just a lot of the things we're looking at seemed like incremental improvements where, maybe on the margin, reduce costs or give maybe patients a little bit better access. But a lot of the ideas would be marginal and really, to a certain extent, perpetuate the status quo system. And so we're trying to figure out what is something in theory that actually fundamentally transforms the system. And I actually go back to my early days as a childhood where we had a family doctor who you could actually call on a Friday and, they would treat you. Or I actually remember with some emotion, actually, our family doctor and the relationship we had with him. And I felt that it was something was missing in the US healthcare system. And my co-founder has a sort of a family of clinicians and nurses and people that work inside the healthcare system as providers, and that they were all dissatisfied as well. Mm-hmm. And so when we came across DPC, it was one of the first things that we saw that actually it wasn't scaled, right? It was a very small movement, and to a certain extent it still is, but it's much further along now and it's growing more quickly as well. But what we observed from DPC is that although it was a small movement, what these doctors were doing was actually working, right? Patients loved it. They were getting great access. Doctors and nurses loved it, right? It was something where they were restoring the kind of the spirit of medicine, right? You could see it. They're actually excited to be at a conference. I remember we went to the first direct primary care conference. They were excited and passionate, as opposed to kind of just sort of dissatisfied and upset with the system. And they were, importantly, showing that they could save money. And so it was just sort of like, what's the catch? Well, the catch was that there's 80 of them. Or whatever. I don't know the exact number when we started, but it was hundreds, not thousands, right, of doctors that were and different providers that were doing this. So we thought, okay, if every American had access to care like this, we actually think this would potentially transform the US healthcare system from first principles, right? And so we thought, okay, well, let's just build a company to support this movement and see what happens. And so that was what we did, and we're still around today doing what we set out to do. So that's quite satisfying.
Yeah, one of the things, and I read about it in my book, Sickened, how the government ruined healthcare and how to fix it. And you'll get an electronic copy of my book for being a guest on our show. We talk about the dissatisfaction of doctors in the healthcare system. Mm-hmm. And I honestly, I don't know any doctor in the traditional system, which I know hundreds of them personally.
Right.
Maybe I've met 1,000 of them. I don't know, but I've never talked to one that likes the traditional system. And, in DPC, I've met probably hundreds of them, and I haven't met one that doesn't like it.
That's right.
And think about how important that is as a patient to have a happy doctor. I mean, seriously, that might sound like obvious, but I don't think most patients realize how much most doctors hate the traditional system, because their hands are tied in the traditional system. They are told what to do, what to order. They're not working for the patient. They're working for an insurance company. And usually a big corporation that is paid by the insurance company. So they're not working for the patient.
That's right. Yeah, I mean, they both there's a reason that that the doctors don't like it, the patients don't like it. It's interesting, actually. There's a large growth rate in DPC is actually coming from employers saying, "Hey, why don't we pay for this? This seems like a good idea. Let's just pay for this on behalf of our patients, and basically let the doctors do what they're going to do." Well, it's interesting. The employers also don't like the status quo system, but they're captivated. They're captured by it, right? And I'll even go so far as saying the payers don't like the system they're in. But a lot of the people that work, maybe if you look at the system likes it because the system generates lots of money and people adopt that system. But when I talk to innovative entrepreneurial people all the time that have come from the status quo kind of third-party pay system on the payer side, and they hated it as well. They were like, I felt like I could have. It's not like there's just a bunch of bad people that working at Sickened or whatever that just want to screw everything up. That they're just in the system, and so they don't like it either. And a lot of them actually leave to try to start companies. They'll often find us and we'll figure out, hey, is there a way to partner and figure this out? So the way I tend to think about it is, it's really all of the entities in the healthcare system, all of this kind of, if you think of it from a game theoretic perspective, all of the players, right, in the game don't like the game, but this is the game,
right?
And so the And so the way I tend to think about it, the only way to fix a system that is that scaled up to that level with all of these actors and players that are sort of in this complicated, Dave Chase calls it a Root Goldberg machine and combined with a Gordian knot. Basically, like it's an untiable knot, and it's this complex machine, right? If that's the status quo, right, the only way to break that status quo is you have to just completely start from scratch. And that's why I think the sort of free market movement and DPC especially, because that's the most important part of the healthcare, from my perspective, system is the primary care system. It's the primary, from my perspective, you need to fix that. And then slowly but surely you can rebuild the system around those new incentives, those new, you've got this price transparent, incentive aligned, very low administrative overhead model. And if you think about the status quo, it's perverse incentives, no price transparency, crazy overheads. So you sort of fix all those things in a net new model, and then you can start from there to rebuild the system. And so that's kind of, it's not just the doctors, it's not just the patients, it's everyone. But I think the doctors honestly are the ones that get the worst deal, and because they're, they went into medicine to support and care for people, and they're not able to do that in a traditional model. And so that's actually a form of kind of, Z-Dog calls it moral, he says basically a form of moral injury being applied to the providers in the system. Anyway,
absolutely,
a tirade, but
yeah, no, that was good. Thank you for that. Doctors used to be and still should be in control of the system. They're the highest, they're the most highly skilled, trained, educated person in the system. And it wasn't that long ago, 30 years ago or so, 20 years ago even, that largely doctors were in charge. It wasn't MBAs, it wasn't administrators, it was doctors were in charge. And doctors would tell MBAs or people in the system what they wanted and what they wanted to do, not the other way around. And there was a doctor that we interviewed, a DPC doctor, and he found out during residency that it wasn't what he wanted to do. He's like, this is not going to work. So he went direct primary care right away out of residency, which is very rare, but we are seeing that happen more, which I love that. That we're getting younger doctors seeing that and moving into the movement. Now, without the pioneers, 14 years ago, like, Dr. Lee Gross and things like that, that have been doing it for over 10 years, they wouldn't be able to do that because it takes time to build that. But I love a quote from him. He said, I figured that in order to fix the system, I needed to get out of the system. And I believe that. I mean, I don't think, and I will talk about it in my profession in pharmacy, pharmacists that are in the traditional system, they think that the answer is to lobby PBMs and lobby insurance companies to pay pharmacists better. That is not going to work. I mean, it's the same thing in medicine. If doctors think they're going to lobby Congress to make Medicare pay doctors better, no, it's just not going to work long term. I mean, instead of a 6% cut this year, they gave a 3% cut, and the AMA cheered and doctors cheered. It's like that's not something to cheer about,
right? Totally. Yeah, no, it's all of those solutions that are sort of proposed. They're all, a lot of them are good ideas, right? They will maybe slightly improve things. So it's not like people are that they have a lot of the time good intention, right? Hey, let's try to. Sometimes it's not good intention, but a lot of the time, actually, people, I believe, come from a place with good intention. But it's just not going to change the system, right? There's been hundreds of billions of dollars been funneled into like value-based care, for example, right? And my view on it is like it's actually a pretty good idea, but it's not working. It's good. It comes from a place of good intention, but we still had a 50% increase in total cost of care over the last decade, right? Which is like, oh, that's a lot. Healthcare was expensive a decade ago. And so a lot of that innovation is just not really changing anything. So yeah, I agree. Like the way to transform the system is you need to really re-architect it and redesign it from first principles, which is a long game, right? I'm not proposing that, hey, everyone, if we just did these two things, then overnight everything's fixed. It will take time, but if you don't have a shot at something, it's definitely not going to happen. So that's kind of what we're trying to do over at Hint.
And I liked what you said about, DPC was kind of the start of what needs to happen in order to fix the system or get out of the system, I should maybe. Because without the primary care, there's nothing else driving it. So what's happened with DPC doctors is they've networked with lab companies to drive prices down. They've
cash prices.
Imaging companies to drive prices down of MRIs. I'm surprised about when I hear what you can get an MRI for in Florida now. Yeah, you can get an MRI for $400 in Florida, maybe less now. I don't know. I mean, it's crazy.
And you can get an X-ray for like $75 in some cases.
Yeah, you can get an X-ray for me. This is a few years ago. I talk about it in my book. South of me for about an hour and a half south of me, $59 for 6-position X-ray on my son's wrist back in 2014. Now, prices probably
went up. There's a lot of work happening with pharmacy. There's lots of innovative happening with pharmacy where it's, hey, can we just get a cash rate for this, or we'll pay a small monthly fee? Yeah.
Yep. I met with a pharmacist over the weekend in Montana that has a cash only pharmacy. And I mean, his prices are incredibly low. And it's amazing how it's usually many times it's low. I mean, people's copays will be hundreds of dollars, and he can do it for $50 or something like that. Right. I mean, so when people use their insurance, that's what makes it expensive. Another thing we're seeing too is now that there's primary care doctors, there's also specialists that are going into either fee for service, because with the specialists, depending on the specialty, it's a little more difficult to do a monthly fee. But they're doing fee for service cash services, and so these primary care doctors can refer to them.
Yep.
I mean,
it's happening. Like we're seeing it happen across the board. There's, the important thing to remember is that something like, in the US, something like 5 to 8% or something of money is spent on primary care, but it should be, in a DPC model that's probably closer to 10 to 12%, right? If you were to scale it out, so which is the point, right? We need to double our investment in primary care at least. But indirectly, something like 60% of spend is sort of dictated by a primary care doctor and their referral. And so if you're able to change the system at that critical junction point, and then have all of those referral pathways that are emanating out of that primary care doctor, have those referred into the new system, whatever that may be, that we're kind of working towards, then you've sort of pretty much solved the problem, right? Like at scale. Now that's a lot to do there, right? But that, I think, sort of conceptually, it's not rocket science. We sort of don't think insurance is necessarily bad. It just shouldn't be the thing that pays for 60, 70, 80% of healthcare. That doesn't make any sense. So there's no other insurance industry in the world where the amount of services that are paid for and covered are done, something like 70% is paid through insurance. Like the only place that happens is healthcare in the United States of America. And so if we can change that and make it, what it take the global average of any industry, I don't know, it's probably more like 15% or something, or 20%, some number like that, gets relegated to very high cost, catastrophic, then unpredictable events, right? And primary care is not unpredictable. It's pretty, and a lot of the things that emanate out of primary care are not unpredictable. The doctor's like, this is what we're going to need to do, right? So, Anyway.
Yeah, absolutely. I mean, we're kind of told lies when it comes to healthcare, and I think it's a little bit ignorance and a little bit that we're lied to about healthcare being expensive. But
Yep.
one of the things that the DPC doctors, the analogies they use is like you're talking about with insurance. You know, if you have auto insurance to cover your wrecked car, it doesn't put gas in your car. It doesn't put tires in your car. I mean, so right. I mean, like you say, you said 60%, maybe 75%, and of course I don't know the numbers. I don't know if you know the exact numbers, but probably, honestly, with healthcare, only 10% of the stuff should, like most insurance, should be covered. You know, catastrophic stuff. Okay, you get cancer. Okay, you have a heart attack. Those things are covered, but. Right. But, routine doctor visits are not expensive. Routine x-rays are not expensive. Even broken bones are not expensive.
That's right. And actually, I just want to clarify, the 60%, what that number is the amount of healthcare that is attributable to a primary care physician referring, as well as their cost, right? So the amount of money that is spent through insurance is more than 60%, right? Like, the number is probably closer to 70. I don't have the exact number, but it's a substantial amount of the healthcare spend runs through the insurance fee-for-service rails. And so, basically solving for that, I think, is a pretty critical problem.
Well, another thing, and let's just go back to what we talked about, or what I talked about early on in our podcast, is that this is not really new. We think it's a new concept, but you kind of talked about it with the relationship with your doctor. 30, 40, 50 years ago, this is how it worked. This is how the system worked. And speaking of DPC doctors and primary care, nowadays in a traditional system, you go see a doctor for a primary care doctor for an eye infection, and he sends you to an ophthalmologist, he or her. You go see a doctor for a broken wrist, and he sends you to an orthopedic surgeon. I can tell you, when my brother broke his arm back, 40 some years ago, he didn't go to an orthopedic surgeon. There was not an orthopedic surgeon in a small town. There was a physician assistant that casted up his arm, splinted up his arm, and it worked just fine. Now there's times where you do need a surgeon when it's a nasty break, compound fracture, all that kind of stuff. But most of the time, a direct primary care doctor can take care of well over 50%. And I'm just making up numbers, but I'm going to guess well over 50% of the things a primary care doctor can take care of. You don't need to be referred to some specialist. Those referral systems and the big system is how insurance companies, how the system makes money.
That's right. Pretty much every single primary care doctor went through ER training.
Exactly.
So the way I tend to think about it is that the status quo sort of primary care relationship is, we'll spend 7 minutes with you, and then the clinically correct thing to do is to make a referral, because we can't do what we need to do in 7 minutes.
Exactly.
So it actually is the clinically correct thing, given the constraints of 7 minutes. But if you remove that constraint, it's like an absurd idea most of the time to make a referral.
Right.
And so again, It's not the doctors, they're not being bad people and trying to mess up the system. They're just like, I've got 6 or 7 minutes here, right? I'm going to do what I need to do. And so, you if you sort of remove those incentives and you kind of let this introduce better incentives and remove the overhead, then a lot of the time those doctors that have that ER training, we've got some clients that actually deliver babies, do C-sections and stuff if needed. Like that. That's not necessarily every doctor, but there's DPCs out there that even have some specialty experience that can do. So what we tend to find is that what happens is that really the scope of what is considered primary care expands. So urgent care typically would collapse into the primary care in DPC model. Some specialist care will end up sort of at least the easy stuff, right? Unless it gets really complicated, will collapse into DPC. A lot of the time we have our clients, they'll take the first mile of like mental health, right? If they have patients that are, just really anxious and want to always come and see their doctor, well, that might just be a mental health thing. And often the doctor, if they spend time with them, they can actually help with some of that mental health.
Right.
And so it's just, you sort of, chronic disease management, if you're a pre-diabetic, well, primary care doctor can help you with your diet, talk with you about your diet and the implications of that and hold you accountable and be available and come up with maybe a nutrition plan. And you don't necessarily need a diabetes-specific verticalized solution that with billions of dollars funded into it. Just let the doctors do some of that work and their teams, or they'll have a health coach as part of their team, things like that. And so you just expand the scope of primary care. You do invest more, right? There is a catch, right? It costs more money has to be paid to the doctors to do this work, but it's but it's not 10 times more. It's, double or triple, right? But double or triple, and then you're going to get way more than double or triple the value.
Absolutely. Yeah. And ultimately patients and patients have to understand this and be knowledgeable about this and be educated about DPC, because ultimately consumers have to drive this. It's got to be between consumers and doctors, and they are. Once patients know about it, this is why we have you on our podcast. Once we educate them about it and they know about it, they're very happy with it. So,
just going to reference this. I saw you throw this up. The doctor-patient relationship is making a comeback. That's kind of the first thing we say on our website. So
tell us a little bit about how to get a hold of you guys if anybody has any questions.
Yeah, you can just on our website, hint.com. You can, all our contact information is on there. We're at Hint Health on Twitter, and if you're interested in learning more about DPC, then we've actually got our annual conference coming up in September. You can find that on the resources tab, which is on our website, and there's summit.hint.com. And we'd love to have you come if you're interested and passionate about DPC. We're really proud of the conference and the kind of the energy it gives back to the community.
I love it. Thank you so much, Zak, for being on our show today. You've helped us realize our goal, which is to educate and empower consumers to take charge of their own health. And DPC is one of the ways to do that, so there's no third party involved. So thank you so much, Zak, for being on.
My pleasure. Thanks for having me.
Listeners and viewers, thank you so much for tuning in. Tune in to our regularly scheduled podcast Monday, 12:30 to 1:30 Pacific Standard Time. Thank you for listening to Health Solutions with Shawn and Janet Needham. Thank you.